Hello and welcome. Today, we're diving into a rare and often overlooked kidney disease, light chain deposition disease or LCDD. This is a systemic disorder where abnormal protein fragments build up, primarily damaging the kidneys, but also potentially affecting other organs. Let's explore what causes it, how it affects the body, and what we can do about it. The root cause of LCDD lies in a problem with plasma cells, a type of white blood cell responsible for producing antibodies. In LCDD, these cells malfunction and produce an excess of abnormal light chains. Light chains are a component of antibodies. These abnormal light chains are structurally flawed and can't be properly processed or eliminated by the body. The exact trigger for this plasma cell dysfunction remains unknown in most cases. However, LCDD is often associated with underlying plasma cell disorders, such as monoclonal gammopathy of undetermined significance, or MGUS, and multiple myeloma. So, how does the abnormal light chain deposition lead to kidney damage? The malfunctioning plasma cells churn out these light chains, which circulate in the bloodstream. These flawed light chains have a strong tendency to stick together and form insoluble deposits. These deposits primarily target the kidneys, specifically the glomeruli, which are the filtering units of the kidney. The buildup of these light chain deposits thickens the glomerular basement membrane, disrupts the normal filtration process, and ultimately leads to kidney dysfunction. This deposition can also occur in other organs like the heart, liver, and nerves, causing damage specific to those organs. The disease progression depends on the extent and location of the light chain deposits. LCDD is considered a rare disease, and precise epidemiological data is limited. Because many cases are initially misdiagnosed or go undetected, the true prevalence of LCDD is likely underestimated. It primarily affects adults, typically in their 50s and 60s. There doesn't appear to be a significant difference in prevalence between men and women. While it can occur in various ethnicities, more research is needed to fully understand any potential disparities. The signs and symptoms of LCDD can be quite varied and often non-specific, making early diagnosis challenging. The most common presenting feature is proteinuria, or protein in the urine, which is an indicator of kidney damage. As kidney function declines, patients may experience fatigue, swelling in the legs and ankles, edema, and high blood pressure. In cases where other organs are affected, individuals may experience symptoms such as heart failure, liver dysfunction, or nerve damage leading to numbness or tingling. Unfortunately, these symptoms often develop gradually, delaying diagnosis until significant organ damage has already occurred. Diagnosing LCDD requires a combination of clinical suspicion, laboratory testing, and tissue biopsy. Initial investigations typically involve blood and urine tests to assess kidney function and detect the presence of abnormal light chains. Serum-free light chain assays and urine immunofixation are crucial for identifying and quantifying these abnormal proteins. However, the definitive diagnosis requires a kidney biopsy. Under a microscope, pathologists can identify the characteristic light chain deposits within the glomeruli. Specialized staining techniques, such as immunofluorescence, confirm the presence and type of light chains involved. Occasionally, biopsies of other organs, such as the heart or liver, may be necessary if there is suspicion of external involvement. While LCDD itself doesn't have formally recognized subtypes, it's important to differentiate it based on the specific type of light chain involved, kappa or lambda, and the underlying plasma cell disorder, if any. Additionally, the extent of organ involvement further characterizes the disease presentation. Understanding these factors is crucial for tailoring the treatment approach. The primary goal of treatment for LCDD is to suppress the production of abnormal light chains by targeting the underlying plasma cell disorder. Treatment strategies typically involve chemotherapy regimens, similar to those used for multiple myeloma. These regimens may include drugs like bortezomib, cyclophosphamide, and dexamethasone. For eligible patients, autologous stem cell transplantation may be considered as a more aggressive approach to achieve deeper remission. In addition to targeting the plasma cell disorder, supportive care is essential to manage the complications of kidney dysfunction. This may include medications to control blood pressure, reduce proteinuria, and manage edema. In advanced cases, dialysis or kidney transplantation may be necessary to maintain kidney function. Unfortunately, there are no known preventative measures for LCDD, as the exact causes are still unclear. Since LCDD is often associated with underlying plasma cell disorders, early detection and management of conditions like MGUS may be beneficial. However, more research is needed to fully understand the relationship between these disorders and the development of LCDD. The prognosis for LCDD varies depending on several factors, including the extent of organ damage at diagnosis, the underlying plasma cell disorder, and the response to treatment. Early diagnosis and aggressive treatment can significantly improve outcomes. However, LCDD can be a progressive disease, and many patients eventually develop end-stage renal disease requiring dialysis or transplantation. Recent research efforts are focused on developing more targeted therapies that specifically inhibit the production or deposition of light chains. Novel agents like daratumumab, a monoclonal antibody targeting CD38 on plasma cells, are showing promise in clinical trials. Furthermore, researchers are investigating the role of inflammatory pathways in the pathogenesis of LCDD, which could lead to new therapeutic targets. Continued research is crucial to improve the diagnosis, treatment, and prognosis of this challenging disease. Thank you for joining us today.